Hi everyone, and welcome to the slide set muscles related to the cervical spine. We did take the spine and specifically the cervical spine this week, so we will be continuing and adding on to that with this screencast on the muscles related to the cervical spine. So the first muscle we'll be taking is trapezius. It is named due to its shape. It's considered to have a trapezoid shape. For this course, we'll only be talking about the upper fibers. There are a middle set of fibers and a lower set of fibers that are related to this muscle, but they'll be talked about in muscles in Clinical Anatomy 2, because they relate more to shoulder and more than the back, or as the axial skeleton. So we will only be doing the upper fibers. Trapezius is a very, very large muscle. It covers quite a bit of the back, as you can see here. It goes from the occiput all the way down to T12. So its upper attachments are the external occipital protuberance, including the medial 1/3 of the superior nuchal line of the occiput, part of the nuchal ligament, and the spinous process of C7. It goes down to the lateral 1/3 of the clavicle of the acromion. This is the upper. So as I said, it covers a fair amount of area here when we look at it. We will only be discussing these upper fibers, as I said, for this course. These upper fibers' functions then are to elevate the scapula at the scapulocostal joint. So that's the articulation between the scapula itself and the thoracic cage. It's not truly a bony articulation, but it is considered a bit of a soft tissue articulation. That will be discussed further next semester. It also retracts the scapula, so pulls it back at the same joint, the scapulocostal, and it upwardly rotates the scapula at the same joint. Its reverse action, if we inhibit the lower parts and stabilize them, it extends the head and neck at the spinal joints when both sides are working at the same time, so we say bilaterally. It contralaterally rotates the head and neck at the spinal joints. So it does have a little bit of a rotation. It also laterally flexes the head and neck at the spinal joints when working unilaterally. Its innervation is a cranial nerve 11, called the spinal accessory nerve, and it arises from the levels of C3 and C4. From here on in, whenever you see an innervation in bold like that, that means that the majority of the fibers or the main innervation occurs at the C4 level. So again, here we see the muscle, and we are talking about these upper fibers. In the next slide, we can see all the various movements. As I said, there is upper fibers, middle fibers, and lower fibers. These upper fibers pulling on the top of the scapula rotate it. Here, these upper fibers, the uppermost, they will lift the shoulder up or elevate the shoulder, and they will help rotate the head. As well, unilaterally or bilaterally when they're working, will extend the head down as towards the back. Now we're going to start introducing the trigger point patterns to the various muscles as we move through. So we see here in the diagram, again, we're only talking about the upper for now. We can see in these diagrams that are done, we look for the X, which represents the spot where the majority of time trigger points can be found. In the inside here, we see just superior to the scapula in these fibers, and then we also tend to find them superior to the clavicle in the anterior parts here. It's said that this muscle is the most common muscle for trigger points because of its relationship in these anterior fibers to this area. It is thought to be the major cause of temporal headaches. So trigger point 1 here, the pain is unilaterally upward along the posterolateral aspects of the neck to the mastoid process. And then it is the major source of attention headache. When it's intense, it is the side of the head centering at the temple and the back of the orbit, the back where the eye is. So your patient may say, I can feel that pain behind my eye. It may also include the angle of the jaw. Ultimately, it looks like a backwards question mark. Trigger point 2 here, which is a little more posterior compared to these two. The referred pattern is slightly posterior to the cervical reference, so slightly behind where we were looking. And generally, it tends to blend into behind the ear, as we see here. The next muscle we're going to talk about is something called Splenius capitis. There are two splenius muscles. There is a Splenius capitis, which we see here, and there is a Splenius cervicis. So I've kind of explained it out to you. The term splenius almost means bandage-like, so it's flat, like a bandage. Capitis means it attaches to the head. So its superior attachments are the nuchal ligament from C3 to C6 and the spinous processes of C7 to T4. So nuchal ligament from C3 to C6 and the spinous processes from C7 to T4. 2, the mastoid process of the temporal bone and the occipital bone, the lateral 1/3 superior nuchal line. So it is the temporal bone and the lateral 1/3 of the superior nuchal line. Its functions, when working bilaterally, they extend the head and neck of the spinal joints. We do get ipsilateral lateral flexion of the head and neck at the spinal joints when working unilaterally. And it does also ipsilaterally rotate the head and neck at the spinal joints when working unilaterally. Its innervation is the cervical spinal nerves, the dorsal rami middle cervical parts. So if we think of taking the cervical spine and dividing it into an upper, a middle, and a lower, this is the nerves arising from the middle cervical. So we see here in the diagram that it's bandage-like in this area here and arising up into this nuchal line and the mastoid process. See it much nicer here, arising here from the area of the cervical spine up into this nuchal line and the mastoid process. Its trigger point is basically pain to the very top of the head, and ultimately the trigger point is usually right in the middle of the muscle that we see here. Splenius cervicis, again, splenius means bandage. Cervicis actually means that it only finds attachment in the neck. It does not go to the head. Its attachments are the spinous processes of T3 to T6, and they arise up to the transverse processes of C1 to C3, the posterior tubercles on those transverse processes. Its function is to extend the neck of the spinal joints when it works bilaterally. It laterally flexes the neck at the spinal joints when it's working unilaterally. It ipsilaterally rotates the neck, not the head, because this muscle does not cross the joint between C1 and the occiput, the atlanto-occipital joint. So we'll see here, if I go back, you'll note here that splenius capitis is here to the head, so therefore it will turn the head. Whereas cervicis only arises up to C1, it does not cross the atlanto-occipital joint, therefore it has no influence on the head. So we say again, ipsilateral rotation of the neck, not the head at the spinal joints. Its innervation is the cervical spinal nerves of the dorsal rami lower cervical. So the capitis muscle was the middle cervical joints, or levels, sorry, and the cervicis muscle is the lower cervical area. You see it here, so rising here from the lower, whereas capitis would be a little higher up to the middle. This splenius cervicis, it's got a couple of trigger points. At the upper end, we find that it causes diffuse pain through the inside of the head, focusing severely behind the eye on the same side, and sometimes to the scalp over the occiput. I've sort of said this with the last couple of muscles. It's going to be quite unusual for your patient, if they haven't felt it before, to say that they actually feel pain behind their eye, and it's not uncommon. The lower end of the muscle, at the angle of it finds pain at the angle of the neck, upward and to the base of the neck. So you see here, the upper trigger points tend to arise. Upper trigger point tends to arise here behind the eye. Lower tends to arise right at the angle of the neck to the shoulder and arises up towards the head. Next muscles we're going to talk about are areas, muscles found in the area of the suboccipital region, so below the occipital bone. These guys are a big deal. We spend a lot of time working here, especially when patients come in with stiff necks or headaches. So you really do need to get to know this area very well. So this represents the upper back of the neck. It is a triangular area. It is located between the occipital bone of the skull and the superior end of the vertebral column between the posterior aspects of C1 and C2. These muscles lie very deep to trapezius and to semispinalis capitis. So if you're palpating, you're going to have to go through those to get to these muscles. So we see them here in the diagram. Here is C1, here is C2. This is the semispinalis capitis muscle here. This is the splenius capitis over here that's been removed. So see, this is a group of very small muscles. So here we've got the occiput area of the skull. And here is C1, here's the dens of C2. And you can see you've got muscles attaching from this aspect of C2 up into the occiput. You've got from the spinous process to the transverse process here, and the transverse process back to the occiput again. So these are relatively tiny muscles, but I can tell you they can be the cause of a lot of discomfort in your patient. So there are 4 muscles in this region. They are considered to be relatively postural in nature, but they do help with some movement of the head. And they are all innervated. All 4 of them are innervated by the same nerve, the dorsal ramus of C1. And C1, this nerve is strictly a motor nerve. Okay, this is only involved in causing the muscle to contract. So let's start with the first one. This muscle is a small triangular muscle. It's mainly postural. Its attachments proximally arises from the spinous process of C2. Get your head around that. Arises from the spinous process of C2 to the lateral part of the inferior nuchal line and the occipital bone. Remember, we have a superior nuchal line and an inferior nuchal line. This muscle attaches onto the lateral aspect of the inferior nuchal line and also part of the occipital bone. It does extend the head and neck at the atlanto-occipital joint, remembering that is the joint between C1 and the skull when it's working bilaterally. Laterally flexes the head at the atlanto-occipital joint unilaterally, and it does somewhat help to rotate the head to the ipsilateral side. And as I said, its innervation is the dormal ramus of C1. So we see it here. Major is right here. So SP of C2 all the way up into this lateral aspect of the inferior nuchal line. The next muscle is rectus capitis posterior minor. So that should tell you right off the top that this is a smaller muscle as compared to major. It arises from the posterior tubercle of the posterior arch of C1. Remember, C1 was ring-like in its architecture, and there was a small posterior tubercle on that arch. So it arises from the posterior tubercle of the posterior arch of C1 to the medial 1/2 of the inferior nuchal line. Remember, major was to the lateral part of the inferior nuchal line. This is the medial half of the inferior nuchal line. It helps protract the head at the atlanto-occipital joint, which is considered its primary movement. It does extend the head at the atlanto-occipital joint when working unilaterally or bilaterally. It does somewhat laterally flex the head at the atlanto-occipital joint. And as I said, dorsal ramus C1 is its innervation. So we can see it here is the minor. So major arose from the spinous process of 2 to the lateral aspect of the inferior nuchal line. Minor, posterior rectus capitis minor, arises from the tubercle on the posterior part of C1 and attaches to the medial part of the inferior nuchal line. The next one is the superior oblique of the head, or obliquus capitis superior. Its attachment proximally is the transverse process of C1. So the transverse process of C1 to the occipital bone between the superior and inferior nuchal lines. So the first two found attachment right on the inferior nuchal line. This muscle finds its attachment between the superior and inferior nuchal lines. Its function is to protract the head at the atlanto-occipital joint, which is its primary. Laterally flex the head at the atlanto-occipital joint unilaterally. Extends the head at the atlanto-occipital joint, working bilaterally. And does somewhat contralaterally rotate the head at the atlanto-occipital joint. Its innervation is the dorsal ramus of C1, as all the others. So we see here in the diagram, we said the transverse process of C1 up to the occiput. It's right here. If we go back to this, it's right here in this diagram as well. So the TVP of C1 to the occiput here. Obviously, if there's an superior oblique muscle, there's an inferior oblique muscle called obliquus capitis inferior. This is a very unusual muscle because it's called capitis, but it has no attachment to the cranium. It arises from the spinous process of C2, remember C2 is the axis, the spinous process of C2, to the transverse process of C1. So you can see it has no attachment to the skull, yet it's called capitis. Its function is an ipsilateral rotator at the atlas at the atlantoaxial joint. Its innervation again is dorsal ramus of C1. So we see it here. We had the posterior major here, posterior minor here, superior oblique here, and the inferior oblique. Remembering, spinous process of 2 to the TVP of 1, no attachment to the cranium. I have said a couple of times with these muscles, or with these nerves and innervation, I've talked about something called the dorsal ramus. I thought I would spend just a moment here to explain that. You can see in the diagram here that this is the spinal cord, and you can see these yellow strings attached. There are two sides to this. One is sensory. This is where sensory information is being brought into the spinal cord, and one is motor function. In other words, it is sending messages out from the spinal cord to have muscles contract. Where we were talking about the intervertebral foramen, that's where this exit would take place. So here is inside the spinal column. Once we get out here, we are now outside the spinal column. What I want you to pay attention to here is the dorsal ramus. In other words, when the nerve has left the ganglion, which is outside the spinal column, there is a branch that heads directly backwards. So when I say these muscles are innervated by the dorsal ramus, that means that at those levels of the cervical spine, there's a branch that heads back posteriorly, which innervates the muscles. And then the major nerve continues forward to further branch in other areas, but there is this branch, this dorsal branch. Remember dorsal, dorsum at the back. It is a branch of nerve that heads posteriorly to innervate. So we say that all the suboccipital muscles are innervated by the dorsal ramus of the C1 nerve. So that would be a branch off of C1 that's heading posteriorly. Something also that's important to understand is something called the suboccipital triangle. And what this is a very deep area. It's between rectus capitis posterior major and the superior and inferior oblique capitis muscles. Why this is important, and you can see it here in the diagram. Here we go, we've got the rectus capitis major, and then we've got the obliquus superior and inferior. You can see there's a space in here. Through here runs a nerve and blood vessels. If this area gets tight and this space narrows, it's going to affect those structures, which can result in headaches, blurry vision, tinnitus, which is ringing in the ears, and vertigo. So it is something to be considered when you are assessing someone and they may complain of neck tightness, upper neck tightness, and some of these major complaints of headaches or blurry vision. It may be something you want to consider when you're trying to create a clinical impression of what you think might be wrong with your patient. So the boundaries are, so superiormedially is the rectus capitis posterior major, superolaterally is the superior oblique, and inferior-laterally is the inferior oblique. Its floor of the triangle is the posterior atlantooccipital membrane and the posterior arch of C1, and the roof is semispinalis capitis. These two, I'm not going to be too concerned with questions, but do understand that there are structures that help protect this vertebral artery and suboccipital nerve that exit through or pass through this triangle. And those are pretty important structures. So again, we see the boundaries here. The suboccipitals generally as a group, we can see one here and one here. Generally speaking, what happens, the pain is referred inside the skull. The patient will have a hard time localizing exactly where it is. There sometimes can represent something called an indurative headache. The pain extends forward unilaterally to the occiput, to the eye, and the forehead with lack of definable limits. So although the suboccipital may suggest an eye discomfort, it won't be in the back of the eye like the others that we discussed. Next are the anterior muscles of the neck. As in the posterior neck, the anterior division has a triangular region as well. The anterior cervical triangle boundaries are the anterior border of sternocleidomastoid, the anterior midline of the neck, and the mandible. It is then further subdivided into smaller triangles. And remember, whenever you have these triangles, it's the body's attempt at creating, shall we say, tunnels or passageways for nerves and vessels to pass through without any concern around them being occluded or stress placed on them, that kind of stuff. So let's talk about the superficial and lateral muscles first. The largest one is a muscle called platysma. It finds attachments on the subcutaneous fascia of the superior chest, so the pectoral and deltoid fascia, so quite large at the bottom. And it arises up to the inferior border of the mandible, the skin, and the subcutaneous tissues of the lower face. Its functions generally are to draw up the skin of the superior chest and neck, creating ridges of skin of the neck, which is its primary action. It can depress and draw the lower lip down and laterally. It depresses the mandible at the temporomandibular joint, but these are minor functions for this muscle. Its innervation is cranial nerve 7, which is the facial nerve. We see it here in the diagram, just how huge this muscle is, but very, very thin. It is just superficial under the skin. If you try to tighten and pull your lips back into a really stern, tight, straight lip, you will see this sort of pull the muscles up in the neck. Here is a picture of it in the cadaver that's been removed to give you a sense of just how large this muscle covers. Again, just attaching up under the mandible and going down in towards the chest wall. Here's the one that we have to know well, and everybody talks about it all the time in massage, and that is a muscle called sternocleidomastoid. Its superior attachment is the mastoid process of the temporal bone and the lateral 1/2 of the superior nuchal line. And it has 2 divisions in its inferior attachments. So it goes to one head is called the sternal head, so it goes down to the anterior superior surface of the manubrium, which is part of the sternum. And the second head is the clavicular head, and exactly as its name suggests, it attaches to the superior surface of the medial third of the clavicle. Its functions: it flexes the lower neck at the spinal joints, extends the upper neck and head at the spinal joints. It is an ipsilateral lateral flexor, so it laterally flexes the head and neck at the spinal joints when working unilaterally. And it is a contralateral rotator, so it laterally flexes the head and neck of the spinal joints, and it contralaterally rotates the head and neck at the spinal joints. So we'd like to say then basically it's an ipsilateral lateral flexor contralateral rotator. Innervation is spinal accessory nerve, cranial nerve 11. So we see it here in this diagram on the left. We can see it has its singular attachment here at the mastoid process and part of the occiput. As it travels inferiorly, it divides in its 2 heads, this being here the sternal head, and this being in behind it the clavicular head. So remember, the sternal head is the superficial part, and the clavicular head lies behind, is posterior to the sternal head. So when we look at its trigger points, and this guy can have a lot of trigger points in it. You imagine all the work it does with poor posture and a lot of things that we do in our society. So if we look at the sternal division first, which again is the superficial division, at the lower end you get pain downward to the upper sternum, which can cause a dry cough. At the mid-level of the muscle belly, you get homolaterally arching across the neck and across the cheek into the maxilla, over the supraorbital ridge and deep within the orbit, which we see here. And then the upper end is the occipital ridge to the vertex of the head. So you're sort of getting the patterns here. Remember, wherever it's solid, that's where the intense pain is, and the more speckled areas is where the pain is a little less. The clavicular head, I find most times, is the more common area for trigger points. In the mid-level of the belly, you get the frontal area, possibly to the other side. I call these the headlights. So patients will say, oh, you're right above my eye, right in my forehead. The upper part goes deep into the ear and posterior auricular area, sometimes to the cheek and the molars ipsilaterally. this is one that I find all the time into these two headlights in the forehead when we get into this, this midpoint. The next group of muscles we need to talk are in the anterior neck are the deep muscles of the neck. So we look at the anterior first. We have something called longus colli. There are three parts to this muscle. There is a superior oblique part, an inferior oblique part, and a vertical part. So the superior oblique arises from the transverse processes of C3 to C5 and go up to the anterior arch of C1. The inferior oblique arise from the anterior bodies of T1 to T3 to the transverse processes of C5 to C6, and the vertical, which lies between the superior and inferior oblique components, it arises from the anterior bodies of C5 to T3 to the anterior bodies of C2 to C4. So you'll see here better in the picture when we look at it how we have these different heads. So here is the superior oblique, here is the inferior oblique, or the lower, and here is the vertical in between the two. Its functions: it flexes the neck at the spinal joints, which is its primary function. It laterally flexes the neck at the spinal joints when working unilaterally, and it contralaterally rotates the neck at the spinal joints. Its innervation is the vertical spinal nerves, those ventral rami I talked about earlier, from the levels of C2, C3, C4, C5, and C6. And that would sort of make sense because of the expanse of this muscle. You would have innervation as it's moving all the way through the cervical spine. The next is longus capitis. So this was longus colli. Longus capitis is probably going to tell you something, and that is that it does attach to the head. Its attachments are the transverse processes on the anterior tubercles of C3 to C5 and up to the inferior surface of the basilar part of the occiput, just anterior to the foramen magnum. Its functions: it flexes the neck and head at the spinal joints, which is its primary function. It also laterally flexes the neck and head at the spinal joints. Its innervation is the cervical spinal nerves, the ventral rami, C1, C2, and C3. So we see longus capitis here. So here was longus colli. Here is longus capitis, and you can see this is the basilar part of the occiput, and it's attaching right onto the occiput of the skull itself. Laterally, the last set of muscles are the scalenes. Again, these are a very common muscle for massage therapists to work at. These guys can be quite uncomfortable, and they do take a little bit of invasive technique to get in to fix them. So we see them here in the diagram. They like the lateral aspect of the neck. A very unique thing to them is that you can see between this anterior head and this middle head, we have the brachial plexus, which is an extremely large bundle of nerves that are leaving the cervical spine here to go and innervate the structures of the arm. We also have a very large artery that also passes through here called the subclavian artery. And you can imagine if these muscles get tight, they can occlude or cut off this blood vessel or impinge these nerves and result in something called a thoracic outlet syndrome. So we are always having a look at these muscles to see if they're causing any issues. So the first is the posterior scalene. So we're going to start at the back and work our way to the front. It starts at the posterior tubercles of the TVPs from C5 to C7 down to the external surface of the second rib. So posterior tubercles on the TVPs of 5 to 7 to the external surface of the second rib. Its function is to laterally flex the neck at the spinal joints, but if we fixate the neck, its reverse motion is to elevate the second rib at the sternocostal and costal spinal joints when we take in a very large breath, and that's known as forced inspiration. This muscle is innervated by the cervical spinal nerves, the ventral rami, C6, C7, and C8. So we see here the posterior in behind of the three, down to the second rib. The second are the middle scalenes, or scalenus medius. It finds its attachments on the transverse processes of the cervical spine, C2 to C7, so we're not in the tubercles here, we're onto the TVPs themselves, to the superior surface of the first rib. So the posterior scalenes found attachment to the second rib, the middle scalenes finds attachment to the first rib, and there's a posterior groove for the subclavian artery. That is just posterior to that groove that sits on top. Its functions: it does flex the neck of the spinal joints when working bilaterally, and when we fix those neck areas, it also laterally flexes the neck of the spinal joints when you're working unilaterally. And similar to posterior, its reverse motor function is to elevate the first rib at the sternocostal and costospinal joints when we have forced inspiration. So posterior goes to the second rib and elevates it, whereas middle scalenes goes to the first rib and elevates it on forced inspiration. Its innervation is the cervical spinal nerves C3 all the way to C8. So we see it here, medius. So there's posterior down to the first rib at the back. Then we have medius that's come here to the first rib behind that subclavian area, depression. The next one is the anterior scalene or scalenus anticus. It is from the anterior tubercles of the TVPs of C3 to C6 to the scalene tubercle on the first rib. So that means that the anterior and middle find attachment on the first rib, and posterior finds attachment on the second rib. I am going to get picky about anterior and posterior tubercles, because you can kind of palpate those tubercles, and it's a big difference as to what you're working on when you're working on a patient. Its functions: flexes the neck of the spinal joints, which is its primary. It laterally flexes the neck of the spinal joints, which is also primary. It also contralaterally rotates the neck of the spinal joints. Its reverse mover action is exactly the same as medius. It elevates the first rib at the sternocostal and costospinal joints on forced inspiration. Its innervation is cervical spinal nerves, ventral rami, typo there, sorry guys, should be C4 to C6. So ventral rami of C4 to C6. So we see here we have the anterior on this side. Please remember, anterior and medius both find attachment on the first rib with the subclavian groove between the two of them, and then we have the posterior that is attached to the second rib. So if we go back here to the initial picture, when I talked about the subclavian artery, it is between this anterior, scalene's anterior, and scalene's medius that we find a small triangle which allows subclavian artery and the brachial plexus to pass through. We have any issues with anterior and medius getting tight, they start to close off this triangular area and can cause numbness and tingling, and lack of a pulse in the wrist if it's starting to block off. And as I said, that is commonly known as thoracic outlet syndrome. The last of the scalenes is its referral patterns and trigger points. You can see they're all over the place. I tend to affectionately work here with patients because I find a lot of junk in scalenes. They work very hard in this sitting posture that we use all the time. Any of the scalenes can refer pain anteriorly to the chest, laterally to the upper extremity, and posteriorly to the medial scapular border and adjacent interscapular region. Anteriorly, persistent aching pain in two finger-like projections over the pectoral region down to the nipple level. Pain to the anterior shoulder is not described as deep and extends down the front and back, in other words, over the triceps and biceps, sort of laying over top of it. It skips the elbow, and then is found on the radial side of the forearm, the thumb and the index finger. That's the classic one. If you're into the scalenes and your patient describes pain in the thumb and index finger, you know for sure that you are dealing with a trigger point in scalenes. Scalenus anterior commonly refers pain posteriorly to the back over the upper half of the vertebral border of the scapula and to the adjacent interscapular region. I've said this many times, you really do need to get to know these patterns because they're going to only help you help your patient when they show up. Whether it's them expressing a pain pattern like this, if it's active, meaning that there's no movements, or if it's a latent trigger point that when you push in there, you get the same referral pattern. Thank you for listening to this slide set, and good luck in your studies.